Welcome to Robert Wood Johnson University Hospital's Health Talk. I'm Dr. Douglas Hoshinsky of Robert Wood Johnson Physician Enterprises, Warren Internal Medicine. Along with diet and exercise, getting a good night's sleep is a key factor in your heart health. People who do not get enough sleep or who have disrupted sleep due to sleep disorders have an increased risk for developing heart disease. We'll learn more about the connection between sleep and your heart from today's guest, Dr. Amit Kalra of Robert Wood Johnson Physician Enterprises, Cardiology Associates of New Brunswick. Dr. Kalra is board certified in both cardiology and internal medicine. Welcome to the show.
Thank you.
Dr. Kalra, tell us a little bit about yourself, your background, and where your office is located, so in case patients want to know.
Yeah. I've had a long-standing history, long-standing interest in both cardiology, cardiovascular disease, and sleep medicine. I'm actually one of the few cardiologists across the country who is dual-boarded in both sleep medicine and cardiovascular disease. I'm a big believer in primary prevention. We focus heavily on preventing heart disease and thus treating any disorder that may contribute to heart disease, such as sleep medicine. Our office is in East Brunswick. We have a singular office, a beautiful building in East Brunswick, and we have a sleep center within the office building, which is now actually part of the Robert Wood Johnson Physician Enterprise, and it's actually one of the only sleep centers within the whole Robert Wood Johnson network. We've been practicing there, or I've been practicing there for the past 10 years.
So tell us now, since again you're actually triple boarded, internal medicine, pulmonary medicine, and cardiology, the association between losing weight, exercising, and sleep and heart disease.
Right.
These are things that are not separate.
Yeah.
These are things that we have to put all together.
True.
Let's put it all together for us.
Yeah. Let's just start with sleep. That's the main focus today. And if you look at sleep and sleep duration, you'll notice that there's a very close relationship between weight, between mood disorders, between longevity, heart disease, strokes, and duration of sleep. Okay, people who tend to be short sleepers, sleeping less than 6 hours per night, have a substantially higher risk of developing heart disease, developing strokes, living longer lives. Similarly, interestingly, people who are extremely long sleepers, sleeping more than 9 to 10 hours per night, have a similar increased risk of poor outcomes. Normal sleepers, somewhere between 7 to 8 hours, seems to be an ideal sleep period.
Sleep itself, there are phases to sleep.
Yeah.
And those are actually quite important.
Right. REM sleep, the deep sleep period, seems to have the highest correlation between development of poor outcomes. So REM sleep seems to be very important. It tends to happen more towards the mid to later part of the night. And often we find that patients who have insomnia, as an example, don't develop as much REM sleep as patients who don't have insomnia. And similar to people who are short sleepers, folks that have terrible insomnia problems similarly have poor outcomes as well.
So REM sleep for the people, for the layman, what does that mean?
REM sleep, I think the simplest way to describe it is just deep sleep. It's a period where you're dreaming. It's a period where your blood pressure is very low, your heart rate drops, and these are apparently very important factors in long-term outcomes where your body gets a rest. Your brain is very active in terms of dreaming and things like that. However, your body is completely relaxed. Your heart rate is lowest during that time period. Your blood pressure is lowest. It's called a blood pressure dip.
So when a person goes to sleep at 10 o'clock at night, wakes up the next morning at 6. During that time, how much of that time do you think they're going through that REM sleep?
Yeah, about 10 to 20% is an average time.
So really minimum amount of the whole time.
Yeah. Yeah.
So they're in the prior phases and the post phases more than they are in the REM sleep.
That is true.
However, they need that REM sleep in order to wake up refreshed and reduce their risk of problems.
Correct.
And we have no idea how to get people into that REM sleep.
No. Interestingly, there's one of the drawbacks, a lot of medications that are typically used for inducing sleep also happen to often reduce REM sleep. So a lot of the medications that we, hypnotic type agents, from over-the-counter stuff like Benadryl to something more powerful such as Ambien, often reduce REM sleep.
So the problem about giving the person a sleep aid is they may fall asleep, but they're not achieving REM sleep, and therefore
Correct.
when they wake up, they're really not through a good night of sleep.
That is correct, yeah.
So normal sleep is the best sleep.
Normal sleep is the best sleep, absolutely. Interestingly, what we've noticed over the past 20 years is that the total duration of sleep that Americans get has substantially reduced by almost 1 to 2 hours per night. Lower now compared to what it was previously. In fact, I think about 30 to 40% of people would say that they sleep less than 6 hours per night. In my practice, which is heavily weighted towards the more elderly patients because of cardiology, we noticed that there's a huge problem with insomnia, simply because as patients retire, they don't have that regular set schedule. They don't have to wake up at 7 o'clock every morning to go to work. So you're more inclined to say, I'm just going to stay up late, watch an extra show, or go on Facebook, or do this and that. And that seems to perpetuate the problem. Insomnia is a big problem in our society, in my perspective, which I think has contributed to a lot of the other issues we talked about.
So again, in order to help reduce insomnia, we have to tell the people to get into a good sleep environment.
Sure.
And that means?
Yeah, so, we focus mainly on two different things. One is the most important thing just being sleep hygiene, okay? Often I tell my patients that if you have issues, difficulty falling asleep, or if you have issues maintaining sleep, really the most important things are to have a very set sleep schedule. We understand that you may not have to wake up early in the morning, but you have to go to sleep at the same time every night. You have to start a sleep routine, maybe an hour to 2 hours in advance of that. And often that includes absolutely no blue light. Blue light is inclusive in a lot of the lighting that we have in our homes, to television tubes, to iPads, to iPhones. So I often tell my patients no screen time for at least an hour before. Create a bedtime routine where you may take a hot shower, you may drink chamomile tea, you may want to avoid the bedroom until you finally get there. The brain has a very, primitive response where, certain chemical reactions start to develop, if certain stimuli are provided, such as walking into the bedroom at nighttime.
Again, the bedroom should be for only one or two things.
Sleep.
Sleep. And having the TV on in the bedroom is not the best of ideas.
Bad idea. Bad idea. True.
Watch TV down in your family room or the living room, and when you're finished, go up to your bedroom without the TV.
Exactly. You want your brain to only associate your bed with nothing other than sleep.
By doing that, our brain does associate the bedroom with sleep.
Correct.
We also want to not be using our iPhone or our phone right before we go to sleep. We'd like
Absolutely.
to not put it on the desk, right next to the bed, because we're going to be tempted to look at it.
Right, right. Difficult to do, but that is exactly right.
So, important tips are the bedroom is for sleeping.
That's exactly right. And patients who have severe insomnia, we often mandate that you're not even going to walk into the bedroom until it's bedtime. You want to only associate the bed with sleep and nothing else. And if you're unable to fall asleep for, let's say 20 minutes, we encourage them to get out of bed, go out of the room, read something really boring, the back of the newspaper as an example, under a warm yellow light. And then once you start feeling a little drowsy, and then walk back into the bedroom again.
Not to go downstairs and turn the TV on.
Not to turn the TV on.
And to put a nice warm light, something easy just to sort of get you drowsy again.
Exactly.
Because we want to still maintain that sleep hygiene.
That's exactly right.
So what happens to the heart during all of this?
Yeah, so, I think the best way to kind of examine what happens to the heart is to really look at the risk factors for heart disease. there's nothing in particular with sleep deprivation or other sleep-related breathing disorders, as an example, that causes a dysfunction within the heart itself. It's really the risk factors for heart disease, mainly blood pressure problems, mainly heart rate problems, other sympathetic activities that may rev up inflammation and things like that, that eventually contribute to heart disease. What happens, what's important to recognize is what happens during sleep. What happens during sleep is that your whole body relaxes, your heart rate drops, your blood pressure drops. And these clearly have been shown to be very important prognostic factors in terms of longevity. Your body really needs that rest. And when you don't get that rest, when your heart rate stays up high, when your blood pressure stays up high, the likelihood of developing future problems substantially goes up, including heart disease.
So then that leads to sleep disorders themselves.
Correct. Yes, so it's a perpetual problem. So patients who tend to stay up more at nighttime tend to eat more often at nighttime, which builds up weight, which decreases metabolism, which increases insulin resistance, which is a risk factor for heart disease, for diabetes, increases inflammation as something that we've kind of noticed when we examine CRP levels, which are a marker of inflammation. Absolutely.
So what we want to do is we want to keep our heart and our cardiovascular disease risks as low as possible.
Yeah.
And again, if we get a good night's sleep, those things will not be exacerbated by sleep itself.
Correct.
So sleep disorders themselves, how do you diagnose them?
Yeah. Yeah, so the biggest sleep disorder that we see in our communities is sleep apnea. There are two different forms of sleep apnea, central sleep apnea and obstructive sleep apnea. And central sleep apnea is a rare disorder, more of a kind of a neurological problem that's not very prevalent, but obstructive sleep apnea is by far the most common form. It's a disorder mainly related to obesity, mainly related to obstruction in the airway. Typically when you breathe, when you're awake, the air freely moves through your nasal passages or through your mouth and into your lungs. Keeps your oxygen levels high and keeps your brain stimulated, your heart, your kidneys, and other organs. When you sleep, all the muscles in your neck go to sleep as well, and your tongue, which is a form of a muscle as well, and that goes to sleep as well. So everything tends to collapse, and any other obstruction that may be in your airway, such as your tonsils, your adenoids, your uvula, other fatty tissue, or extrinsic fat compressing down, tends to further collapse the airway. Your tongue may even roll backwards, and that may collapse the airway. So all of these things lead to decrease in airflow going into your lungs, which then can lead to a drop in oxygen levels, which then leads to the brain having to wake up to open up the airway, which then leads to non-restorative sleep.
So things that bring these things to mind is, one, if you have a sleep partner, they hear snoring.
Correct. Yeah, so that's the most common symptom that we hear, right? Snoring or gasping. So if you have, a few breaths of lowered inspiration where no oxygen's really going in, and then finally the brain gets stimulated, then you may take a big gasp, a large breath to get more air in. And that's often, one of the telltale signs that we hear from bed partners is that, that you're snoring and then you stop breathing for a minute, or it seems like you stop breathing for a minute and then you take this big gasp,
That when the bed partner says that they stop breathing,
mm-hmm.
That's the scary thing when you hear that.
Yeah, yeah. So it's not that they're not breathing, it's what's really is happening is that the airflow isn't really going into the lungs.
So that wakes them up.
And that wakes them up.
And then they don't get into REM sleep.
Correct, correct.
So I've got someone who comes into my office, and they come in with their wife, and they've got high blood pressure, and maybe they're slightly overweight also.
Mm-hmm.
Since they're overweight, their neck is going to be a bit thicker than they normally.
Correct.
And therefore, when they sleep back, the tongue can obstruct.
Yeah.
Or because of the relaxation of the airways itself, they're not breathing as well.
Right. Yeah, I mean, there's some really simple tools that we use to screen people. Weight, a BMI above 30 as an example is a
BMI
reasonable,
meaning the basal metabolic index, which is their weight divided by their height.
Correct. Their neck size. Neck size is greater than 16.5 inches or 17 inches is a high correlation with obstruction. simply opening your mouth and looking inside, and being able to see the back of the throat very easily or not easily. If you're not able to see the back of the throat very easily, very high likelihood of having obstruction.
So someone comes into my office like that. Do I send them to you for evaluation, or do I send them to an ear, nose, and throat first to look for an obstruction?
I think that's a very good question. I think the question really is symptoms. If patients don't have a lot of risk factors, such as high blood pressure being the biggest one of them, or don't have heart disease, and they have no symptoms whatsoever, meaning they don't complain of waking up feeling tired in the morning, waking up with headaches in the morning, feeling tired or sleepy in the daytime, we often have our patients fill out a little questionnaire called an Epworth sleepiness score, which is a few simple questions that kind of ask them, how sleepy they are in the daytime, meaning like how they feel driving, how they feel as a passenger, how do they feel in the afternoon if they're reading a book under a quiet situation. Very simple questions that can help us really differentiate how sleepy they are in the daytime. So if you have a patient who's not very sleepy, has really no symptoms, and has no risk factors such as high blood pressure or heart disease, then I think that probably going in ENT may not be a bad idea. But if they do have any of the other things, then really they may have significant sleep apnea, and that should be treated.
Okay, so I send them to your office. What is the patient going to? What's going to happen?
Yeah. So after the exam, if I agree that yes, there's a high likelihood that you do have sleep apnea, then the next thing is to really figure out how severe it is. How much does your oxygen level drop? And the next step to kind of figure that out would be to do a sleep study.
And for people who never know what a sleep study is, what is a sleep study?
A sleep study basically has two components to it. One, we're trying to figure out, are you moving air? So we have little cannulas attached to your nostrils or next to your nostrils that kind of measure airflow. So we can kind of see how much air is moving in and out of your lungs. Second component to a sleep study really is oxygen levels. So we're trying to figure out, does your oxygen level drop when you have a drop in airflow? So if we see both of those two things happening together, that's considered an apneic event.
And at the same time, we're going to have an EKG attached to their
heart.
Yeah,
so there are a lot of other bells and whistles. So we can examine a lot of other things. So we can look for, like you said, EKG abnormalities. Does your heart rate drop? Does your heart rate increase with that kind of an event? We can have little probes attached to your legs. Are you having limb movements? Often restless legs or limb movement disorders can be associated with these problems. We can have probes attached to your head, looking at your brain waves to see, does your brain wake up with this activity? Do these activities happen more during REM sleep? Does it happen more during non-REM sleep? We have meters attached that can help us understand whether this only happens on your back, whether it happens on your right side, your left side.
So a full diagnostic of what your sleep is like.
Yeah.
And it can be done at your office.
Correct. So there's two different forms of sleep studies now. The advent of technology has really allowed us to kind of shift the whole diagnosis of sleep apnea from the office to the home. So actually the majority of sleep studies that we do now are done at home. They're not done in the office. Really the only studies that we would do in the office are patients who have risk factors or have known heart disease or have known lung disease, anything that may drop oxygen levels for other reasons other than sleep apnea. So if you don't have any of those other major heart or lung problems, then it's very reasonable to do a sleep study at home.
Now we do the sleep study at home, and it shows obstructive sleep apnea.
Correct.
What's the next step?
Yeah, so once we've made the diagnosis of sleep apnea, really the next step is to figure out how bad is it. If you have severe sleep apnea, meaning that you're having many events per night where your oxygen level drops due to obstruction, and a number that we kind of use is the apnea-hypopnea index, the AHI, which is something that's reported on the sleep study reports. If that number is more than 30 events per hour, that's considered severe sleep apnea. So you're having frequent events. In those cases, CPAP, which is a mask that you wear, which allows air to kind of flow into your airway under pressure. So what that pressure does is blows open the airway with every breath, allows that air to get past the obstruction and into your lungs. That kind of method of treatment is by far the best and the most well-substantiated treatment we have.
So CPAP, as that people know it,
Correct.
continuous positive airway pressure,
Yep.
allows the airs allows to actually bypass the obstruction and thus continue the airflow into the lungs.
Exactly.
So the person will have a sleep study prior to being evaluated with the CPAP mask, and then again afterwards.
Yes. So, there's two ways to start CPAP therapy. One is to do a study, a subsequent study called a titration study. And these studies have to be done in the office setting because what we're doing is we're bringing you in one night. We attach a CPAP mask to you, or we allow you to kind of go through many different CPAP masks, see what kind of mask fits you best and what kind of mask you feel most comfortable with. Let you sleep with it. It gives you a trial run and gives us an opportunity to kind of go through all the different settings to see at what settings do we completely eliminate your sleep apnea, kind of coming up with your prescription. Okay. That's one methodology. A second methodology is to just start AutoPAP. AutoPAP, these machines have a fair amount of technology built into them. So there are certain type of machines that have computer algorithms try to predict on their own, what your pressure setting should be. So we can often bypass the office study altogether, just order AutoPAP, and the machine tries to predict on its own.
And it's portable.
These things are very portable, yeah. The overall size of CPAP machines has improved dramatically over the years. They're very quiet now. They're generally small. They often have a water reservoir attached to them, which allows humidity to kind of go with the air, which makes it far more comfortable. Often patients, when they travel, they just leave the water reservoir behind, which makes the machine only about this big.
So what's nice about it, again, from all the years we used to have this big contraption in front of you attached to something on the floor, to this little portable thing makes it that much easier to use.
Absolutely, absolutely.
And the other thing is the bed partner. How do they feel about the CPAP machine?
They are more happy than anybody else, far more happy than you are probably. The bed partner will often report no snoring, which is a big improvement, that they no longer hear the gasping, that their bed partner sleeps through the night often. So these are, very important things.
Socially extremely important things.
Extremely. They can actually sleep with them.
Right. And not having to go into two separate bedrooms because of the snoring.
Exactly.
The other important thing is that this could possibly help people with high blood pressure.
Yeah, so so that's the next important question is, what positive effects does treatment have on preventing problems? So, when we look at treatment of problems, the two things we need to focus on are symptoms and all the medical issues that your doctors may be worried about. So the symptoms are snoring, gasping, waking up feeling exhausted, or waking up with headaches, or feeling sleepy and drowsy in the daytime. Those are obviously very important things that we want to treat. And those are things that we almost see immediate positive benefits, and where, even after the first night of treatment, the patient may tell us that was the best night of sleep I've ever had. Then there's the more long-term problems, blood pressure, heart disease, preventing strokes, things like that, which have been shown to, I think that's a more complicated topic, where much like a lot of other diseases, if you have already developed heart disease, if you have already developed severe high blood pressure problems, or if you've had a stroke, or if you've developed rhythm problems of the heart, then it may be a little difficult to kind of reverse course and prevent future problems from happening. But if you have not yet developed a lot of those issues, which is really where our focus is, meaning primary prevention, then we've really shown some very good results that treatment of sleep apnea really does prevent future development of blood pressure problems, or future development of diabetes, or future development of heart disease.
Important point is, again, primary prevention to prevent heart disease.
Correct.
If we can prevent it, better than waiting until after the effects. Exactly,
because once disease develops, we'll take cancer as an example. Once you have stage 4 cancer, which is kind of end-stage cancer, it's very hard to go backwards. But in terms of prevention, if you can catch something very early, then preventing future problems can have greater benefits.
Important, again, being both pulmonary and cardiac, if you can reduce the cardiac disease by helping the lungs, we reduce the risk of heart disease.
Absolutely.
You know, I can tell you from experience, I have a patient who had severe diabetes with apnea, went on the CPAP mask, and his diabetes is much better controlled. Hemoglobin A1Cs have dropped almost down to normal.
Yeah, yeah.
And the truck driver who's falling asleep at the wheel is no longer falling asleep at the wheel.
Which is critical.
So it's very critical, and in fact, a lot of the commercial driver license exams are now incorporating sleep apnea into the risk factors in order to keep truck drivers from falling asleep at the wheel.
Absolutely.
You know,
absolutely.
We've heard recently about train operators.
That's correct.
Who had sleep apnea.
That's correct.
So hopefully, by patients coming to you, we reduce the sleep disorders and improve their overall health and improve their sleep.
Exactly.
Allow them to get into the REM sleep.
Yeah. So allow them to get more restorative sleep, longer duration sleep, sleep that's more productive, and improve their metabolic cycle so they're more energized in the daytime, thus maybe giving them more energy to do exercise, for them to have a more stable mood and not to have anxiety or depression and things like that, which are highly linked to poor sleep. So
by treating their sleep disorders, we reduce their other cardiac risk factors, reduce their psychologic risk, we reduce some of their psychologic risk factors, improve their overall health. So like other risk factors such as heart disease, high blood pressure, diabetes, sleep disorders should be up there also.
Oh, most definitely. Highly correlated. And you spend 40% of your day sleeping. So you have to think that what effects that is having.
Thank you very much for being here.
Absolutely.
And thank you for everything you've talked about, the fact of how important sleep is and the fact that it's so involved with everything else, including heart disease.
Exactly. Thank you for having me.
This concludes today's episode of Robert Wood Johnson University Hospital's Health Talk. Please remember that the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral number at 1-888-MD-RWJUH. For more information about our cardiology services, please visit us at www.rwjbh.org/heart. Thank you very much for being here, and thank you for all of your advice.
Thank you.